Hi, everyone. Welcome. If you could chat in your name, your pronouns, and where you work, that would be great. And we will get started in just a few moments. If you're just joining, if you could put your name, your pronouns, and where you work in the chat, that would be great. And we'll get started in just a few moments. Okay, well, we will get started. So today we are focusing on internal work. We don't have an outside speaker, but we have Stacy Sandy, who's our data analyst, and Amber Johnson, who is our QI coach, who will be presenting today about data updates and hosting a little bit of a discussion with you about improvements we can make within the collaborative. So I will let you both take it over.
Thanks. Are you able to screen share our slides for us, Elena?
Sure. One moment.
Thank you. Hey, everybody. It's so good to see your names and faces today. We appreciate you giving us your time. We'll start our agenda for today. I know many of you because I've been around a few months now, but I'm Amber Johnson. I am doing quality improvement coaching for CPCQC. And if you want to go to the next slide, Elena, we will do kind of a brief overview of what we're going to cover today. We're going to start with just a reminder of some of the changes that happened to our patient level data collection, just to make sure that we're all on the same page with those changes. And then our intern Carly is going to give you an excellent update on cannabis guidance. Stacy is going to lead a Q3 data review for you all. And then we're going to end with some team presentations on how things are going at some of the facilities. So next slide. This slide probably looks familiar to many of you, especially if you are the data champion and you are used to filling out these patient level forms. So as a reminder, this is the form that we use if a patient screens positive for substance use. So this is for all patients who screen positive. And there's a few important changes that we want to highlight for you. You started using these forms as of October 1st, and so they should be familiar to you and your data champions. But we just wanted to clarify any questions that you might have had. First of all, in the top left, I want to highlight to you that we updated our inclusion criteria. We only fill out these forms for patients who are admitted for birth, so not antepartum admissions, unless the patient births during. And we don't want you to complete this form if the single substance that was identified is cannabis. And we're going to talk a little bit more about that in the following slides. On the top right-hand side, we're noting for you that at the request of some of the hot teams, we changed patient level. Sorry, Elena, I don't know what happened to your slides. There we go. Okay. We changed the patient level circumstances. So many of you were letting us know that there were some extenuating circumstances that impacted your ability to fill out these forms completely. Some of those were incomplete prenatal care, some patients leaving against medical advice. And so we added in a completely new section for that. You no longer need to comment those areas, and we'll be reporting back the input that you give us on that. So let us know how that goes. That's a new improvement. And then in the middle section, we're highlighting the fact that we refined and updated how we are collecting race and ethnicity data. We'll talk a little bit more about this when we're giving you the actual data output for Q3 and what that's going to look like moving forward. But just as a quick review, the way that we used to collect race and ethnicity didn't align with most hospital EMRs. It also didn't align with vital statistics and birth certificate data. And so we wanted to be sure that we were collecting race and ethnicity data in a really meaningful way that made the burden of data collection on your site easier. And then it made it more meaningful when we're analyzing the data and our ability to identify disparities in care. So that is new this time around. And then finally, on the bottom right-hand side, we're highlighting the fact that we are now asking you to identify categories of substances versus the individual substances that the patients are identified as using. And so we still have listed the substances that fall under each category because it's easy to forget where some substances fall, and still there as a key for, but rather than getting specific, we just need broad categories so that we can classify what type of clinical management is appropriate by category. So to raise your hand or chat if you guys have had any struggles with this new data collection form. If you love it, give us a thumbs up. We love your feedback on it because we put a lot of thought into how we made these changes. And we're really looking forward in the next data collection cycle in Q4 to showing you how these changes are actually able to reflect in the data that we're able to give back to you. All right, next slide, Elena. One of the biggest changes that we made on that data collection form, and we've spoke about this previously, is that we are not asking hospital teams to fill out that patient level form if the patient screens positive for substance use and the only substance identified is cannabis. And we know that this can be a little bit of a contentious issue, but we wanted to give a little bit of background on how our team came to this decision. And one of the biggest players was the fact that our national program, the AIM national program, who administers and runs this patient safety bundle that guides our work, actually is not collecting this data. And they're not collecting the cannabis only data for a few different reasons. One of the main reasons that they're not using cannabis only data in this safety bundle is because cannabis as a single substance or in the absence of polysubstance isn't a significant contributor to maternal mortality. And the base goals of this AIM safety bundle is to impact maternal mortality outcomes. So really, this is a way that we can align our data collection more closely with the AIM national program. And then secondarily, a lot of the participating hospitals let us know that the burden of having to fill out these patient level forms for all patients who screen positive for cannabis only was just too large. So many patients were screening positive for cannabis only, absence of any other substances. And that burden of data collection was actually discouraging hospitals to participate in a meaningful way. And we didn't want that to hold up more meaningful data collection and clinical care around some really important substance use issues, such as opioid use. And so those are the two main factors that we use to make this decision. We're open to hearing your feedback and questions on it. And Carly is going to give some more information on that moving forward. So we can go to the next slide, Elena. We do not want this decision to be perceived as us downplaying the impact of cannabis use in the perinatal period. And so the question that we're ourselves is, does this mean that cannabis use during pregnancy and postpartum is okay? And the clear answer to that is no. And our decision to not collect on cannabis only substance use screening is that it's a data reporting issue versus a clinical care issue. We know, and the data shows us, review for some of that here shortly, this use has effects and it can harm the parent and the infant. And while you don't need to submit a patient level form for cannabis only users, we do still think that clinical care is appropriate for these patients. And because we know that that's an important way to attend to these really important clinical issues, Carly's going to give us an overview on what clinical care should be for patients who screen positive for cannabis use during the perinatal period. So you can go to the next slide. And I will quickly introduce Carly Swenson, who is our fearless intern and is going to give you some evidence-based guidance on cannabis screening and care. Thanks, Carly.
Perfect. Okay, can you go to the next slide, Elena? Thanks so much. Hi, everybody. My name's Carly Swenson. As Amber mentioned, I'm a CPC/QC intern this year, and I'm also a researcher in the cannabis consumption during pregnancy space. So when we talk about clinical care of patients who are pregnant and at labor and delivery who are using cannabis, there's a few important components of their care that we walk through, including refraining from judging these patients, current recommendations, explaining the effects of cannabis exposure on fetal development. As Amber mentioned, it may not be the biggest contributor to maternal mortality, but there are effects on fetal development that are very important. Talking about the potential legal implications of consumption. And then often people don't look at cannabis in the space of a substance use disorder, even though cannabis use disorder is a very prevalent disorder among vulnerable populations. We're going to talk about dispelling some of the myths and answering questions, and then some available handouts for patient education. Next slide, please. Thank you so much. So when we talk about substance use during the perinatal space and at delivery, one of the most important things we can do is reducing the stigma. So if we're trying to care for these patients and their infants, the first thing that we can do is to not ostracize them. So instead of referring to their cannabis abuse or that they're using drugs or drug abuse, we want to use more neutral terms like cannabis use or substance use. And also in the cannabis space, maintaining some sympathy for a lot of these patients who do report medical consumption. They're saying they're so nauseated that this is the only thing that's helping them. So just approaching it through that lens can be very helpful. Next slide, please. Okay, we do have current recommendations from professional societies, and their obstetricians should be telling them this through their prenatal care. They're relatively blanket statements. We have the American College of Obstetrics and Gynecology and the American Academy of Pediatrics that do have the blanket statements out that providers should be discouraging consumption during pregnancy and postpartum. Next slide, please. Okay, and then when we talk about some of the effects of cannabis use, this is more helpful in early intervention, still relevant going forward to future pregnancies, that there are adverse fetal effects of cannabis consumption, including effects on brain development, some physiological outcomes like smaller size and higher risk of. We're also seeing some behavioral changes at adolescence. And then there are subsequent exposures like harm from second smoke or cannabis exposure through breastfeeding that are still relevant, even if these patients have already delivered. Okay, next slide. Okay, and then talking about the potential legal implications of cannabis consumption during pregnancy, as we all have been talking about recently. It's a Schedule I drug, though it's legalized in many states. So the legality can become confusing, especially for patients, especially when it's even confusing for us. So we do want to talk about the updated Colorado regulations when it comes to cannabis consumption during pregnancy that CPC/QC had two recent incredible conversations with Child Protective Service with. So if you want recordings of those, I'm sure you can talk to she'd be happy to give you those. But being sympathetic and explaining that there are potentially legal implications is important, so patients aren't blindsided if they do get a report to CPS made. And if you want access to Colorado law, we have that on the Scan Me right there, and you'll get these slides after the fact. Next slide, please. Okay, getting to the component about cannabis use disorder. So cannabis alone does not qualify as a substance use disorder. However, there is a cannabis use disorder that patients may or may not have during, before, or after pregnancy. Some of the questions you might want to have or ask to your patients include, is it interfering with their roles and responsibilities? Do they feel like they're being a good parent still? Does the child have a sober and responsible caretaker? Are they able to make it to work and school? Are they being affected by their cannabis use, which would warrant references out to services for substance use disorder? And are they concerned with their consumption rates? And then One important note is that Tough as a Mother, which is what this QR code will go to, is it's important to note that being pregnant and having a substance use disorder does make you a priority for substance cessation treatment. And they have specific programs that are welcome to pregnant patients as well as people with children. So letting the patients know that there are pregnancy and parenthood specific resources available can be very impactful. Next slide, please. Okay, and then we do have some handouts. This is the old CDPHE handout on marijuana during pregnancy. They're coming out with the updated 2022 version soon. But it's important when giving patients complex medical information, especially if they're consuming cannabis and other substances, it might help to give them some handouts so they can mull over it in their own time and not in a high stress environment with a clinician. So again, this is one reference put out by CDPHE that can be helpful to patients. Again, that QR code will take you there. And next slide. Okay, information. If you're interested in cannabis consumption during pregnancy and the rates and what we can do about it, I do have one link here to PRAMS, which is the Pregnancy Risk Assessment Monitoring System that does collect research grade information about cannabis consumption during the perinatal space. Feel free to scan here or to me. As I said, I do work in the cannabis consumption research space. So as we know, it's quite a prevalent issue in the hospitals right now. So any further questions, feel free to reach out. But the major conclusion is just that we're not saying that cannabis use is not a problem or it's not alarming. It's just not something that's being a major contributor to maternal mortality, which is the end goal of this program. So I'll throw it back to Amber.
Thanks, Carly. We know that we're a little fast and furious, but we're super thankful for Carly for putting together those resources and the QR codes. There's lots of links in those slides. Elena will share out these slides at the end today because I think many of those resources would be valuable for you to even have on your units at the hospital. So some of those practice statements could be valuable. Certainly the CDPHE guidance on sort of the legal issues with cannabis use can be helpful. And so thanks, Carly, for that. So we can go to the next slide. And I'm going to hand it over to Stacy, who's going to introduce you guys to your Q3 data. Thanks.
Hi, everyone. I'm Stacy Sandy, as my colleagues introduced. I'm the data analyst at CPC-QC, and I will be going over the data that y'all do such a good work at collecting and submitting. And here I'll tell your story and what we do with it. So next slide, please. So this is actually since the first time that we're going to present kind of cohort level data on positive substance use screening, aside from the preliminary data that we presented back in August. Of the 8 hospitals that submitted hospital level data, the number of positive screens was 6%, which is very much consistent with the data on substance use in the perinatal period. And although only 83 patients admitted for birth were identified with substance use after being screened, only 75 of our patient level forms were received on patients that screened positive. So there's a discrepancy in that. And there were even more hospitals submitted patient level data, hospital level data, as you can see this. 8 out of the 18 hospitals submitted hospital level data, while 11 out of 18 hospitals submitted patient level. And it gives a percentage rate in the numbers in regards to those submissions that we received this quarter. Next slide. So here's Q2 versus Q3 data submissions for hospital level data. As you can see, there is a good number of patients that submitted or hospitals that submitted in Q2, 11 hospitals, while 8 only submitted in Q3. And if you don't see your hospital there, it's because we didn't receive data submission by November 7th. So next slide, please. And here we have the same thing, but with patient level data forms. We have Q2 versus Q3. And again, we have more submissions in Q3 than Q2. However, there were less positive patient submissions for patient level data forms. Again, if you don't see your hospital here, we didn't receive the data submission by November 7th. Next slide, please. So this is just a highlight on some of the quantitative data that we changed on the hospital level form. It's not really a form in physicality like the patient level form. However, when you submit it in REDCap, it is like in a form submission. And the orange is actually what we have recently changed. It correlates with the changes of race and ethnicity, and that is categories in your EMR as well as with CDPHE and vital statistics birth certificates. And we also simplified the categories of the substances being used, which also identifies and correlates with the patient level form. Next slide, please. So what happens to all your data whenever you submit it to us? This is kind of how our means of telling the story. So we are comparing here the percentage of patients that were screened for substance use disorder, depression, anxiety, and ACEs, and social determinants of health in Q2 and Q3. As you can see in Q3, there were no screenings reported for ACEs, but overall, the percentage of screenings for the cohort has gradually increased, and that's great. It's such a win for y'all to be seeing this and continue screening your patients that are admitted for birth. We're encouraged that universal screening seems to be moving forward, meaning that standard of care to all patients, and universal screening is the first step. So next. Here we are looking at a run chart of your overall substance use disorder screenings over time. I know it's a little awkward on the x-axis, as you can see, it goes from monthly to quarterly because we did change our cadence and data submission. However, that dotted line of 2022 kind of signifies that changeover from monthly data submission to quarterly. As you can see, this is from March of 2021 last year to only September of this year. So go ahead and next slide, please. This is the same scenario, but this is only for screenings on depression over time from March of last year to September of 2022. Just as a reminder, we continue to try to reach our cohort goal of screening at least above 90%. So next slide, please. And this is the overall cohort anxiety screening over time from March to September. As you can tell, there's a gradual increase for screening for all 3 data collection cycles in the past 3 periods. So it looks really good. And so it shows you guys are screening your patients that are being admitted overall. Next slide, please. Go ahead, Amber.
So this is just a visual way to remind you guys of the changes that we did in the race and ethnicity data collection. And as it's pretty clear just at a glance here on the left is what the data looked like when we used to collect it. It's relatively limited. We didn't differentiate race and ethnicity. And then on the right, you can see that there's much more detailed data that we're currently collecting. And there's clearly different categories for race and then ethnicity. So we are looking forward to getting feedback from you guys about how this looks, collecting your data, how well it aligns with your hospital EMRs, and if there's any struggles with getting level forms. There's opportunities for us to improve the data that we're collecting. And so we're curious to know if you guys have had trouble getting the patient's race and ethnicity off of EMR chart, if you're able to get the patient level race from patient self-report at the time that you're filling out the form. So if you have any comments on that, comment them in and let us know how it's going. Next. I think this is me too. Thanks. So this is a view of the payer type for the overall cohort patients that were admitted during Q3. Those are in the green, that side by side with the payer type of the patients who screened positive for substance use, and that's in the blue. And on this slide, I think it's interesting to note that of the patients who screened positive for substance use, again in blue, roughly 50% had Medicaid or Medicare, and the other 50% had private insurance. And there's a lot of misconceptions about substance use. We know this. One of those misconceptions can be that substance use varies greatly by socioeconomic status or by insurance type. But the data really tells us that although the type of substance or the actual substance being used does vary by race, ethnicity, socioeconomic status, and insurance type, the overall rate of substance use does not. So this is why universal screening is so important. We know this as well. But you might be inclined to believe that privately insured patients are less likely to screen positive for substance use. But this slide here makes it clear to us that All patients are at risk for substance use, regardless of their socioeconomic status and their insurance type. So we thought this is a pretty powerful slide to reflect that. And this tells us that of the screenings you all are doing, by universally screening, we're not identifying disparity in care, meaning that not all of the patients identified by a positive substance use screen, only in one insurance type or payer. Next slide.
Okay, that's me. Now we're going to switch over to look at data submissions and look at the collection for race and ethnicity. Now, again, the patient level data submissions are only on patients that are admitted for birth that have been identified or screened for substance use. Again, if we look at this, we see that the majority, some were white, the least majority were race at 3%, and it breaks it down to races that were accounted for during this Q3 data submission. Next slide, please. If I speak too fast, you will get these slides so you can go over and review this. But here we do the same thing again, as we look at ethnicity separately as our new data collection mentioned level form. And we can see that a large proportion of the responses are blank. So 85% of them were blank in regards to ethnicity. And I know with the changes of how we were collecting previously to how we're collecting now, we're hoping that this will get better over time, but we do want to hear your, if there's any struggles you're having, or if you need any support, please let us know and put something in the chat or email us. If you're running into any issues of obtaining the ethnicity information from your EMR, please let us know. Next slide, please. Now here again, we are looking at the quarterly data that we started collecting on October 1st related to a request on adding additional information pertaining to extenuating circumstances for patients. And we placed it on the patient level form, and we are collecting that in REDCap as well during your data submission. The information actually adds some context to the patient level data, and as you'll tell through the remaining slides, we kind of tell the story of the data. And as Amber noted in the patient level forms, we're now adding these categories to our data collection forms as a means of looking forward, of using the data moving forward. And we found out that there were almost 5% of known or unknown prenatal care for our patients to us on patients that screened positive for substance use, and 3% of them had out of birth. They were born at birth, hospital, and then 1% left against medical advice, AMA. Next slide, please. Now here again, just gives a story to the data. We're looking at the percentage of newborns that were born to patients who screened positive of substance use and then were discharged to either parents. If you look, note that a large portion, almost 65% of the infants were discharged to either parent, while 20% were and we want you are welcome to any context in the form, like there's a comments part where you can tell us anything pertaining to the infant's disposition to tell more detail of the story. Next slide, please. Okay. Here we are looking at the 75 patient level forms that we received in Q3, and of the substance categories reported on pregnant patients that screened positive for substance use during pregnancy. As you can tell, the highest ranked here is depressants. It's kind of hard to see, but again, you'll get these slides. 59% of them, of those 75 patients, 44 out of the 75 patients actually had depressant usage. And then the second one was stimulants at 16%. And opioids and stimulants, polysubstance followed, and then MOUD, and so on and so on and so on. As a reminder of which substances fall under which category, there's a key to the right that kind of defines which goes under each category for those substances. Next slide, please. Now, in looking at the Q3 patient level data submissions on clinical care practices provided to patients that screened positive for substance use, and that this is for any substance. 71% of those reported having consultation with a social worker prior to discharge. 48% reported being counseled on recovery treatments prenatally or during birth admission, and 33% reported receiving recovery treatment services at any point prenatally or admission. Next slide, please. Now we took that funnel from quarter 3, and we wanted to compare it to quarter 2 to see kind of how we're doing. And this is from the preliminary data that we presented back in August. We thought we'd look at the number of patients, even though they're greater in quarter 2 data submissions that we received. The clinical care practices are higher in quarter 3 in regards to the patients admitted and the percentage of those clinical care practices. Now, go ahead.
Thanks. Yeah,
Mhm.
we, Stacy and I think that like this funnel graph is one of the most powerful ways that we can show sort of what clinical care practices are or are not happening for screening positive for substance use. And clearly there's room for improvement to increase the clinical care for these patients. The clinical care practices such as consultation with a social worker, referral to recovery treatment, counseling, and then actually receiving treatment, we have a really large focus of in 2023. Now that we are doing much better with our screening, and we see that as a cohort, our screening rates are kind of constantly increasing over the last couple of data collection cycles. Now that we're identifying these patients in a more evidence-based way, we need to make sure that we're doing the evidence-based clinical care appropriately for patients who screen positive. And this graph here, especially on the right from quarter 3, shows us that there's clearly opportunity for us to improve the amount of clinical care that we're offering for positive screens. We'll talk about more in the next few slides, but a couple of the ways that CPCQC is going to help facilitate improving clinical care practice cohort wide is we're going to start to talk more about how your facility might form a multidisciplinary group to support these clinical care practices for the frontline nurses or obstetric providers who may not know what resources are available for clinical care practices. And we're also going to work towards helping facilities do resource mapping so that you know specific resources within your community or even within your to be able to offer more comprehensive clinical care for all of these positive substance use screenings.
I noted here, but I think next slide is, yeah.
Thanks. So this slide is a little busy, but we'll try to talk through it. Of the 75 patients that screened positive for substance use, this is how we're breaking down the clinical care practices. And the little subset of bar graphs on the left side is showing us the percentage of patients who were offered counseling with a social worker prior to discharge. And in the yellow, you can see here that those are the patients that did receive a social work, did receive counseling prior to discharge, and that was 48%, while 32% didn't, and it was unknown for 19%. And so again, room for improvement. All patients who screen positive for substance use should be able to receive that counseling prior to discharge from the hospital. We're interested in why that isn't happening, or what are the barriers, and what we can do as a cohort to improve that number. In the middle set of bar graphs looking at is the number of patients who received room services. And in the yellow, you can see that 33% did. In the blue, you can see that 45% did not. And then in the gray, another 21%, it was unknown. So again, clearly room for us to improve the number of patients who are actually receiving recovery treatment services. And then finally, on the right side, the last set of bar graphs is the number of patients who were referred for recovery treatment services. And at the very least, we think that this clinical care practice should be standardized at your setting. I think if you don't have the capacity to offer treatment and to have patients receive treatment services at your facility, there shouldn't be a lot of can't refer that. And so we could see that clearly in the graph on the far right-hand side, that 35% of those patients who screen positive were not referred for recovery treatment services. And it's something that we want to look really closely at, making sure that you have the resources, making sure that you know what's in your community and where you should be referring patients who are screening positive. Next slide. So this, I think, is our final slide, and our team here thinks that this is a really powerful slide. So this slide is the specific patients who not only screen positive for substance use, but they screen positive for opioid use or medication for opioid use disorder. And so we know that these patients are the most at risk, especially for maternal suicide and drug overdose. And so this is where we want to target a lot of our efforts. Of the 8 clients who were screened positive for opioid use during their birth admission, only 1 of those was documented as having received counseling, and 1 was referred to MO. And so we want to actually congratulate Montrose because that patient came through Montrose Hospital. So, they're doing it right. Right. Not only did they screen this patient, they identified the substance this patient was using, and then they have offered the appropriate referral and care for this patient. And so, but that leaves us with 7 other patients that the question is, why isn't that there's a gap in the care for them? Why did we actually chart that we identified opioid use during the perinatal period, but then failed to offer counseling, MOUD, or referral to MOUD treatment? So huge opportunity. We're open to hearing feedback on if this is a gap in data collection or if this just truly in clinical practice aren't being delivered at your facility, and what it is that we can do to help facilitate you guys having the resources necessary to offer this thing and for these clients. I will note the caveat here that you can see on the right hand. One of these clients who was identified as opioid use during the perinatal period, it was documented that that patient left again medical advice. So it's possible that they didn't have the opportunity to offer counseling and MOUD. So we'll give that caveat. Even so, that leaves us with patients who, again, were identified with opioid use during the perinatal period who didn't receive the appropriate clinical care. So what we're going to do, you all are going to receive facility level information from Q3. And Stacy and I will work really hard at identifying possible case reviews that you could do on these clients. So if some of these came through your facility, then we will highlight those for you. We recommend that there's some chart review, maybe even a multidisciplinary clinical review for what this patient's clinical course looked like while they were at your facility, and identifying opportunities that were maybe missed to offer these type of clients appropriate care. So Elena, I think that that's all we have for our data presentation. We are happy to receive comments, feedback, any questions that you have.
Thank you both for sharing that. Does anyone have any comments or questions for Amber, Stacy, or Carly before we head into team presentations? You're welcome to unmute yourself or chat them in, and I'm happy to read them out loud. Okay. Well, we will move into the first presentation, and we will have PSL go first, which is Lisa Becker. And Lisa, do you want me to share your slides for you, or do you want to share them?
That would be amazing. And shout out to Elena. I was having trouble with my software, excuse me, getting the slides to populate. So she did all of this. They look beautiful, and I'm very grateful. There isn't any main point to these slides other than to just talk about some things that y'all may have run into as well in trying to screen and some patients that you may have seen that might have had similar issues to ours. So next slide. So with the screening tools, as everybody here knows, the first step that we implemented with this project was to try to screen universally and to reduce the kind of bias and stigma and normalize the process for all of the patients admitted to labor and delivery. I chose the TAPS tool for a couple of reasons, because it screens for the last 12 months and it screens for multiple substances. A lot of the screening tools work, so that's not something I'm trying to promote separately. When we started rolling this out, I did get feedback from the nurses that some of the patients didn't really understand the nature of the tool as well, and they didn't necessarily have a comfort level describing the goals of the screening tool to the patients. So that little white note there is stapled to each of our handwritten tools that we hand out to try to give some information to the patients and let them know that this is a universal thing, why you need to do it because of the prevalence, unfortunately, of maternal mortality with suicide and overdose. I think that part has been helpful. What has been a challenge, and this may be the case for some of your hospitals as well. In the last 2 years, we have had a lot of turnover with staff. Understandably, a lot of the nurses who may have had some burnout from COVID might have moved positions or moved to be nurse practitioners. Many of our nurses who didn't have absolutely compelling reasons to stay in Denver chose to be travelers. The upshot of that is that we end up educating a new group of nurses about what we're trying to do every 3 months or so, and then lose them, when they move on to their next facility. There's good and bad to that. I'm happy to have information get disseminated to other states and other hospitals, and maybe that will help patients in other areas. It has meant, though, that we don't have a percent of screened patients that we would like. I'm still working on that, and the word is that we're going to have a more stable group of travelers next year. Next slide. I think the thing that I am happiest about this year with our system at Press St. Luke's is that we got onto the Colorado naloxone project. Don Stater, Stater Opioid Consultants, is the CEO and creator of this. The goal is to put naloxone in the hands of at-risk patients to reduce the risk of overdose death. And we were able to bring this into labor and delivery because we see OB/ER patients. Ordinarily, this is distributed through the regular ER, but since we see the OB/ER patients, the pharmacy did allow us to have this on our floor as well. I just want to let you guys know that Dr. Stater is absolutely right. Whenever we have approached patients about being given naloxone themselves, just so nothing happens to them, or for someone they love, so that nothing happens to the people in their communities, the nature of the conversation changes instantly. When you tell them that you just want to give them something to keep them safe, they start looking at you, they start being more interactive, they realize that it's not just, judging or trying to, make them change their habits, but actually trying to keep them safe. So I think that has been a really, really positive thing in our program. Next. Oh, and there's the contact information for that. So we, Dr. Stater would like to get as many hospitals involved with this as possible. That's the contact information, and he's very good about getting back to you in a timely fashion. And his colleagues are all great as well. Next, this is an oddball slide, and again, it was just a different situation. We had a patient who came to labor and delivery in withdrawal. She is actually someone who was stable and in recovery through the Denver Recovery Group. And she was on methadone. She was arrested and taken to a facility in Douglas County, and they did not have methadone in the facility to be able to treat her. What ended up happening is that they tried to switch her over to Suboxone. She went into withdrawal. She had 2 ER visits. She finally ended up coming to us, and we were able to get her back onto her methadone maintenance dose. 2 things about for any of you who have a patient comes to you from the Denver Recovery Group, we learned later that they will hand deliver a patient's methadone dose to whatever facility they're in, which I did not know, and is very useful. And my maternal fetal medicine specialist that day knew someone who knew an ACLU lawyer who is trying to work on this as evidence of inadequate or inequities in care. And we may actually make some progress on more of a state level with this. So I would love to hear if any of you had had a similar situation, so I can pass that on and we can, maybe make some good change. Next. So what I'm hoping to do for this year is to try to have more of the nurses view and learn from the lectures that CQC has to offer every month. We actually had our first watch party on Monday for the Child Welfare on Labor and Delivery lecture. Only a few people, unfortunately, were able to come because, as you know, it can be crazy on labor and delivery, but it stimulated some really, really good conversation. And I'm very excited about keeping that conversation and that learning process going. I also have committed to trying to give updates at our department meetings every couple of months with new ideas and get input. We've actually had more input from our generalist colleagues, and I hope that will lead to some positive change as well. So I think that's all there is, and I'm happy to answer any questions.
Thank you so much, Dr. Becker. Does anyone have any questions for Dr. Becker?
I'm just going to throw it out there one more time. Do the naloxone project. It's so great. It has made such a difference for us.
Yeah, and if you want to get involved, you can contact them through the link that Dr. Becker put, but we're also happy to do a warm handoff. We work very closely with Dr. Stater. And so if you want to get involved, feel free to reach out to us and we're happy to connect you as well. Great. Well, thank you so much, Dr. Becker. Their slides will be included in the follow-up as well. So if you have any specific questions, we will include Dr. Becker's contact info too, if that's okay. Okay, so the next presentation is St. Vincent's, and I have your slides as well if you want me to share.
Yeah, that'd be great.
Hold on, let me just find them. Okay. Okay. There you go.
Awesome. Thank you. So my name is Alicia. I will be talking on behalf of St. Vincent Healthcare in Montana. I am the nurse educator for mother and newborn. So I'm the one who inputs all the data and does everything for our site. So I was just going to talk a little bit about some of the challenges with data collection and inconsistencies that we've encountered since we started. So we can go to the first slide. So just a couple things I just wanted to touch base on that I'm sure some other places are feeling as well. When we do hospital level and patient level data, like I said, I'm the only person reporting the data. So a lot of times that means I'm physically looking through all of the charts every month. I do have a report built in Epic that will pull certain things for me, but in order to do the actual data, you have to go in and look through the majority of the charts and compare with my report, which is very time consuming and kind of like we talked about earlier, a lot of them do test positive for just marijuana. So I'm just kind of throwing them out. But a couple of things that I've encountered is that they test positive for the report that they only use marijuana. And then a lot of times we don't get a UDX on marijuana. And so we'll get a cord on the baby, and then we'll find out that they also were positive for their drugs besides marijuana. So I feel like it's multifaceted. I'll get into that in a little bit, but I have to refer to the care management team for more details. They were unable to assist in actually filling out the forms because they were having a hard time seeing all the patients. They're being pulled to multiple units besides just the labor and delivery unit. So they're having a hard time doing the forms, even though they're doing the work at the bedside. It was just one more thing they felt like they couldn't do. So then I go in and review the notes from the care manager under the baby and the mom. So I have to kind of glean all that data myself from what I'm getting from the notes. So whether they were referred to something, if they had treatment, I'm reading through all of those notes in the chart. Just like the last presentation stated, we have had a ton of turnover. So going through training with new hires and travelers constantly with what's required for charting. Because on the chart, I have no way of knowing what was asked, what was reported, that kind of thing. And the lack of results entered a huge deal. So trying to increase our percentage of patients screened so that we actually have data to report. I think we can go to the next slide. And then as I kind of touched base on before, our providers are not always great about getting a UDS, and if as marijuana, they might not always get a UDS. So then I was actually waiting for cord collection results, which our care management team saved for me, the cords that came back positive. So then I could actually see what substances they used, because if they didn't report it and it wasn't on, so I didn't have a UDS to go off of what they were positive on, I had to wait for that cord to come back. But then also having to revert to see where they were at that point, because sometimes we wouldn't find out until after they were discharged if they didn't have a UDS, which was very frustrating. Substance was used. So then our care management team has to follow up outpatient, which is even more of a disservice to our patients because we're not catching that while they're here and being able to make those connections while they're actually here. Inconsistency with the SDOH answers and the cords results, I talked about that. And then now the new workflow I have that actually has been working the best is getting my report in Epic and then filtering those positive to compare with the care management. I've actually found that the process is working good, and I'm actually finding the most amount of data from that. Next slide. So our goal was to increase the completion of the SDOH. We were having large percentages of them just not screened at all. And we used the audit C+2, which is embedded into our SDOH. So 65% we were getting 65% of our nurses to fill out the SDOH in the audit C+2 versus our EPDS screening, which was mid-90s. So we really wanted to have them both be in the 90s. So we started doing paper screening for that. We were delayed in October due to high census, so we had to roll that out in November. So we've only been doing that for 10 days, but I've got a lot of good input. And it's increased nurse satisfaction so far because a lot of the questions are sensitive, and we felt like we were getting more honest answers, I guess, on paper than actually having the nurse go through it. And you know, that specific language, I feel like that can be used sometimes, can determine what answers they give you. Next slide. And then I just threw this in here for our future goals. Just a multiple disciplinary work group, hopefully we can form, and then doing some more expert training, increase our SDOH screening to 90%, and consider ACEs screening. And then we do want to do the naloxone also. And that's it.
Thank you for sharing, Alicia. Does anyone have any questions for the St. Vincent's team?
I do. First, Alicia, thanks so much for the work that you're putting into this program. It seems like your facility's ability to participate largely hinges on the work that you're putting in for data extraction. So thank you for the hard work. I'm wondering, since it sounds like a lot of the data is coming from you going back into the patient's chart and then abstracting it from different locations, whether or not they received a consultation or whether or not they were referred for treatment. Do you think there's room for the printed patient level data form to live somewhere either on a patient's hard copy chart or on the nurse's clipboard for the patient or with the nurse's SBAR sheet so that it could be more actively filled out during the patient admission stay? Or is that not really a great workflow for your facility based on sort of there's no clipboards or there's no hard chart to be.
I did think about that. And we do have a small hard copy chart, which, not much as I'm sure most facilities, same thing. So we kind of, I did bring that up. I'm not sure the consistency of it getting done when, like I said, our care managers felt like they had too much on their plate, which is a little disconcerting to me because they're still going in and talking to these patients. But I did find so much of a discrepancy in, we are working on our UDS screening right now, and I do feel like that is going to help a ton, because if we can identify those moms earlier and be more consistent with getting a UDS, I will have those answers earlier in admission versus waiting for that cord result to come back. Because like I said, a lot of our babies have been discharged by then. So waiting for the cord results, has a problem with, as a lot of different problems. One, the mom's already gone home with the baby, unless that's a different reason. Two, we're not actually finding out what is positive. And so we don't have that opportunity to connect with her. I mean, the care managers allowed to discuss other things with them, but they probably haven't referred her to treatment because they didn't know what she was exactly positive for yet. So we actually are going to do a little bit of work on our UDS screening, which we're kind of already doing with our system hospitals in building a consent. So across the system, we're screening for the same thing for UDS. And I do think that's going to help because it'll just make our providers, have to do it on these, specific list of things, whether it's 5 or 7 things. If they're positive for that, then we're going to do a UDS. So I think it's just going to identify it sooner and give us more of an opportunity to take care of that different. It's going to help with data collection.
I had a question, Alicia. You in your slides were referring to SDOH screening. Does that stand for social determinants of health? Does your social determinants of health screening include substance use disorder screening, or was that meant to be substance use disorder?
Yep. So our social determinants of health is we rolled that out earlier this year, so we're screening for that on all of our patients, but ours is embedded into the social determinants of health. So sorry, I should have clarified that. So our
I kind of figured that it was probably embedded.
Yep, our screening for alcohol.
Because I know for many people it's not.
Yep. So ours is right in it. It's just another link that they click on. It opens it up. And so all of that now is on paper with everything else, with transportation and, all the other things that SDOH goes over. So I should have referred to that because that's mostly what I care about is the alcohol and drug screening, which comes out of the SDOH. But
oh, yeah, that makes sense. Thank you.
Great. Well, Alicia's slides will also be available after this. So if you have any questions, you can refer to that. But that's it for our coaching call for today. And we will see you in December for our end of year celebration. If you have any questions or would like to meet with us before then, before the holidays get crazy, feel free to email us. But thank you all for attending today. It was great to see you all.